tears, or there is a instability of the tears there, or there is evaporation of the tears. So, which creates ocular discomfort, ocular symptoms like redness, like irritation, visual symptoms, and so there can be subjective and objective signs. There can be subjective and objective signs. So it is associated with hyperosmolality, it is associated with inflammation in the eye. So why is it important to address the dry eye? Why is it? Because number one, because the prevalence of dry eye is very high in the community. How much? In India it is around 40%. How much? Around 40%. So, 2 patients entering into clinics or in the OPD, one will have dry eye. So much common it is. So, the high incidence, high prevalence of the dry eye makes it a very public health problem, a public health hazard. The number second problem is the economic burden. Economic burden, because we prescribe drugs which are costly, and patient has put lifelong. And patient has put lifelong, like lubricants, like anti-inflammatories. So economic burden. In India it has not been estimated, but in USA around $8.3 billion is the annual economic burden on the community. That's a very huge economic burden. That's a very huge. So there are 2 things: the prevalence, and other is the economy. So the prevalence is very high. There are a lot of patients, and number second, the economic burden is very high. So there is a lot of money involved, especially for poor families, poor patients. The economic burden is very high. Those who can afford is okay, but still, the economy of the country, if it gets affected by spending on a particular disease, it affects the overall economy of the country. So next, so as I told you, we do some things like subjective symptoms, and second is the objective assessment. Other is the objective assessment. Subjective symptoms means that patient will complain something. We give a questionnaire to the patient. What problems do you have? Then he will tell, I have this problem, I have this problem. This is subjective. Objective means that we do a test, we do the tests, we do the staining, we do the shimmers, we do different tests. They become abnormal. We do a slit type examination. They are abnormal. So there is a shift. There is a shift. Shift means people who are symptomatic, who have symptoms, they may not have signs because their damage is not okay. Okay. Those who have signs, those who have objective symptoms, objective signs, may not have symptoms. So it is vice versa. So what we do, so some patient lands into our OPD or into our clinics, what we should do ideally, what we are not doing. We have to hand over a questionnaire to them. We have to hand over a questionnaire to them. We have to tell them, are you getting some symptoms? Are you getting some symptoms? And what is the intensity of the symptoms? Like 1 will be mild, 2 will be moderate, 3 will be severe. What symptoms we should ask? Suppose one symptom will be redness. One symptom will be redness. Other will be foreign body sensation in the eye. Okay? Third will be the photophobia or sensitivity to the light. Fourth will be visual disturbance, visual problem. The clarity of vision is not there. So these are the subjective symptoms. So we grade, we give them a questionnaire, we tell them what symptoms you have, you grade how much is the intensity of these symptoms, grade 1, 2 and 3. So then we assess how much patient is symptomatic, how much it affects the quality of life or quality of vision. So we see the impact of symptoms and impact of symptoms on the quality of vision. So if a convinced patient has problems, he has symptoms, even if the signs are not defined or they are not listed or they are not present, still we will label that patient as dry. Okay. Then we come to the signs. Before we go to the signs, I will give you some idea about the classification. Of dry. So dry eye, there are two components. Rather three components. One is the tear film is made of 3 layers. It's made of 3 layers. Anybody can tell me? You tell me what are the layers of the tear? How many? Slow talks. Now, you see? Very good. So there are 3 layers of it. There are 3 layers of the tear film. One is the mucin. One is the mucin. Then second is the aqueous. And top of it is the lipid layer. So mucin is secreted by what? Mucin is secreted by the goblets. Goblet cells are present in the conjunctiva. They are present in the conjunctiva. Aqueous is secreted by what? Aqueous is secreted by the lacrimal gland and the accessory lacrimal glands which are in the fornix. The names of those? Glands of Klaus and Wolffitt. They are in the fornix of the conjunctiva. Then this is the aqueous layer. Then is the lipid layer. Lipid layer is yes, very good. That is secreted by meibomian. So what is the function of the lipid layer? Anybody knows? You will get up. Auntie, what about? You know?
So she does.
Very good. So lipid prevents the evaporation of the acid. So I tell this, if we have a sea of water, if we have sea full of water, and we sprinkle petrol on it, only oil on it, we sprinkle oil on it, it will not evaporate. So anything which has a lipid on its top will not evaporate. So the lipid layer prevents the evaporation of acid. So you can have now mainly 2 problems in the tear film. One is the aqueous deficiency. One is the aqueous deficiency dry. Other than this, you can have abnormal lipids. You can have abnormal what's called evaporative dry. That's called evaporative dry. So we can have aqueous deficiency or we can have evaporative dry. What can lead to aqueous deficiency? There can be problems with the lacrimal gland. What can be the problem of the lacrimal gland? No. First of all is the damage to the lacrimal gland. That's an autoimmune disorder. That's called Jogren's syndrome. So it's immunomediated. This is called primary Jogren's syndrome. In it there are 2 things. One is the decreased tear production, and other thing that affects the salivary gland. So 2 things. One is the tears, other is the salivary gland. So this is called primary Jogren. Then we have the secondary Jogren. Secondary Jogren is somebody has a multi-system disorder, like systemic lupus erythematosus, collagen respiratory disease, rheumatoid arthritis, like that. And then it secondly autoimmune affects the lacrimal gland. It is called secondary Sjogren's syndrome. So primary is once it affects the ears and salivary. Secondary is once patient has already metahead SND, and secondary it affects the lacrimal gland. Then you can have a congenital absence of the lacrimal gland. What's called alacrimia, absence of the lacrimal gland. Or there can be obstruction of the ducts of the lacrimal gland. Lacrimal gland has 4 or 5 ducts which can get obstructed. What can be the cause of obstruction? Any psychiatrist. Any psychiatrist psychiatrizing conjunctivitis. That can affect the flow of the actors. So we can have primary Sjogren, we can have secondary Sjogren, then we can have the problem with the depth of the lacrimal gland. So it will give rise to primary aqueous deficiency. Primary aqueous deficiency. Then the evaporative drive, the evaporation in which the mebumin glands. What can happen to the mebumin glands? They secrete normally oil. What can happen? They become obstructed. They become inflamed. They become red. Their ducts become vascularized. They become atrophic. They are lost. How are the mebumin glands in the eyes? They are present in the upper dorsal, they are present in the lower dorsal, they are present vertically, anterior to posterior, like this. They are present vertically. Suppose 30 or 40 in the upper lids and 20 or 30 in the lower lids, but they are present like this. Okay. So if there is atrophy of them, it will not secrete the oily secretion. Or there is infection or obstruction, it will secrete in abnormal oils. What's called a frothy secretion. It will not prevent evaporation. Okay. So this is called the evaporative drive. And it is also called one of the terms posterior biliary. Posterior biliary, or other term for this is mebumin gland dysfunction. What's called mebumin gland dysfunction. So it will secrete an abnormal oil which will not prevent evaporation. So this is the main cause of dry eye this time in the world. Mebumin gland dysfunction is the main cause of dry eye, and incidence is very, very high. So what can these are the what can other way lead to more evaporation? Suppose somebody has atrophy. That will cause evaporation. Somebody has proptosis. That will cause more evaporation. Somebody has, there are the extrinsic factors. Allergic eye disease. It can cause inflammation in the mebumin glands. It can cause evaporative dry. Contact lens wearers, they cause inflammation, and it can cause mebumin gland inflammation. That can cause. So these are two diseases which are associated with posterior biliary. One is the contact lens, and other is the allergic eye disease, or vernal catarrh, or simple allergic disease. Then there is one more third important that is if the patient has suppose drug toxicity or preservatives in the drugs, they cause a dry state in the eye. And other cause is the vitamin A deficiency, what's called xerophthalmia. As you know, vitamin A is very important for epithelial maintenance, corneal epithelial cells, then conjunctival epithelial cells, and its deficiency can lead to xerosis, dryness. And it is, what's the first symptom of vitamin A deficiency? Night blindness. Because it affects the rods. Then there is one more that's called the wettability. That's called as wettability. also decreased wettability of the cornea or conjunctiva. Decreased wettability means that if the corneal surface is uneven, or the conjunctival surface is uneven, or the lids are uneven, it will not wet the cornea or conjunctiva uniform. So this was a broad classification for the dry eye. So this I have told you already. So what are the symptoms? What is those I have told you? Patient can have burning, dizziness, foreign body sensation, itching, rash, pain, blurred vision, and some dry eyes can have increased water. Which dry eye has normally increased water? Which can have? You can be right, you can be wrong. Don't be afraid. You walk very dry eyes and have more watering. Because once there is more evaporation, there is a reflex. There is a reflex to secrete more tears. Okay? So sometimes more watering does not mean patient does not have a dry eye. So selective examination, if you see the selective examination, what are the tests we do? Let's come straight forward now to the diagnosis. Patient of dry eye with these symptoms, with these questionnaire, now it reports to OPD. What should we do? We should do two things. How much? Two things. We should put some fluorescence in the eye and see the stain. See the staining. What are the different stains? One is fluorescent, other is rose bengal, other is glycerin green. These are three types. So we stain the conjunctiva and cornea. We stain the conjunctiva and cornea. Number second, we can assess the tear production. That's assessed by what? Shimmer's test. That's called a Shimmer's test. And number third, we can do an assessment of the neighboring glands. That's called meibogrammetry. So these three tests are mandatory. One is fluorescent test or rose bengal test. Second is Shimmer's test, and third is meibogrammetry. These are absolutely mandatory. There is no confusion about it. So people don't know how to put the fluorescence in the eye. Anybody can tell me how to put fluorescence in the eye? Now what should we put on the fluorescence strip?
Anesthesia. Xylocaine, sir.
No xylocaine.
No xylocaine.
Because xylocaine contains preservative.
So for NSA
So
liquid.
it will affect the staining pattern. Okay?
It's a normal
Mr.
sir.
Oh, you come forward. Come forward. So what we have to do, we have to do the fluorescence strip. We have to do a fluorescence strip. Then we have to put some solution on it. Then we have to just with the tissue paper we can dry it a bit. Just put the lower corners down and put light on the lubricant. So if you are putting a lubricant, it's wrong. Why? Because lubricant is disgusting. Number second, if you are putting a chlorobacter or xylocaine, it contains preservative. It's again wrong. If you are putting a normal saline, maybe that's a good option. So now if you are putting a drop, you can put an antibiotic, but that should be preservative free. That should be preservative free. You cannot put any, suppose moxifloxacin with preservative, you cannot put it. So if you are moxifloxacin without preservative, you can put it on the system. So then you stain it and you can see the, what do we see? First we see the conjunctival stain. You see the conjunctival stain. Then you see the corneal stain. Then one more thing very important. That's called T-part. That's called tear breakup time. Tear breakup time. So once the tear form, once there is a tear form, it breaks somewhere. It breaks somewhere. That is by a line or that's a hole, small black spot. Suppose you put fluorescent to stain the tear film. So then you see, once patient blinks, he opens the eye. The time starts now. Time starts now. Normally the tear film breakup time is around 10 seconds. If it is more than 10 seconds, it's a good tear film breakup time. If it is less than 10 seconds, it is abnormal tear film breakup time. Can you tell me, anybody tell me why? Because within 10 seconds we blink. Within 10 seconds we blink. After around every 5 seconds we blink. So if it is suppose it gets the tear breakup time is less than 5 seconds suppose. So cornea will have dryness. There will be problem with the vision. You can not see clear. That's why the 10 seconds is important. So nature has created that the tear film breakup time is around 10 seconds. And we blink of every 5 to 7 seconds like that. So that there is no problem in the vision. Suppose the cornea becomes dry, you cannot see clearly. So number one, I told you the staining pattern. Number second, I told you the tear film breakup time. Third important thing is the tear film height. Tear film height. This fluorescent staining near the inferior is. You can see here. You can see here. This is the tear film height. It is around this, and these are the spots. Why the tear film breaks? These black lines or spots. This is a uniform tear film staining with the fluid. So if there are the appearance of black spots, this means the tear film has broken, and we have calculated the time. From the last blip to the appearance of the first black spot or black. Number 7, the tear film height. How is the tear film height? This is height. Lower lid, there is a height. There is some tear here. There is a height. That's around 0.7 mm. Around 0.7 mm. So if it is less than 0.7 mm, that means there is a tear film deficiency. One more thing, there may be, on the slit that we can see, just I want to finish it with this only, that once the cornea or eye becomes dry, there is a formation of filaments or mucus blocks. Okay? Filaments are like degenerated epithelial cells, they can have mucus which gets adherent to the corneal surface because of the dryness. And other is the mucus blocks. Mucus blocks contain mucin. It contains mucin. And along with the other proteins and even foreign body dust, it also gets attached to the cornea because of the dry state is around. So this is the slit lamp examination. Then we have the Schimmer's test. Then we have the second test is this Schimmer's test. That's the Schimmer's test. What is the Schimmer's test? It's a paper which is around 35 mm long. How much is it? 35 mm long paper. Then we put it, we bend it in front, then we put it in inferior corners, and then patient lies just with his eyes open in a slightly dark room, and we measure how much is the wetting after 5 minutes. So if it is more than 10 mm or more than 15 mm, it is normal. If it is between 5 and 10, it is borderline. If it is less than 5 mm, it is dry. Okay? Less than 5 mm is diagnostic of dry eye. Between 5 and 10, it is borderline. Above 10, it is normal. There is one more Shimmer 1 and Shimmer 2. Shimmer 1 measures the basic and reflex secretion. Now if we put a xylopy in the eye, it will block the reflex secretion. And it will tell us about the basal secretion. So that's called Shimmer 2. That's called shimmer too. Just I want to finish with what is staining pattern. This is the
Turkish. The second way.
this is the paper. This is the paper which is put in the ensuing corners and it is wrapped in like this. Then you have made the batten of the paper. One more thing, we have the corner staining pattern. We have the corneal staining pattern. If the cornea conjunctiva stained with it, staining what? Fluorescein or rose bengal, then we documented how much is the staining. More the staining, more the dry. More the staining, more the dry. How we stain the cornea like this? This is the staining pattern. This is not a staining pattern. This is the impression psychology of the conjunctiva. So I want to tell you something about the staining pattern. Staining pattern is like this. Suppose this is the eye. This is the cornea. So this is the nasal conjunctiva and this is the temporal conjunctiva. So it is divided like this. So this is number 1, number 2, number 3, number 4, number 5, number 6. Conjunctiva, nasal conjunctiva is divided into 3 segments, 1, 2 and 3. Cornea is upper, middle and lower. Okay? And this temporal conjunctiva, 4, 5, 6. Then we give three points to each. Nasal conjunctiva 3 points, cornea 3 and temporal conjunctiva 3. How much is total? 9. Total 3, 3 and 3. Then we see the staining. Suppose it's a mild staining, we will tell 1. Grade 1. If it's a more staining, it will tell grade 2. If it's a more extensive stain, confront stain, it's called grade 3. Okay, so out of these 9 points, if you have more than 3.5, how much? If you have 3.5 staining pattern, then that is diagnostic of the dry eye. Suppose somebody has only symptoms, he does not have any stain. He has dry eye, but damage to the cornea or conjunctiva has not yet occurred. Okay. Then the third most important test is called micrography. That's called micrography. These are the basic tests. These are the basic tests. That's called micrography. What's micrography? We see the glandular pattern in the list. So there are different machines for that. There are different machines for that, like one's called meter. They have infrared camera. They have infrared camera. They put the lid down and then they scan the lower lid and they see the measurement gland pattern. So normally measurement glands are full. If they are short, it's grade 1. And how many glands are short? How many glands are absent? On that there is a classification of measurement gland dysfunction. Grade 1, grade 2, grade 3, grade 4, grade 5 means there are no glands at all. Glands are absent. So more the deficiency of glands, more increase mobility. So this is called micrography. Normally it can be sometimes done on an auto-refractometer. So auto-refractometer, you put the lower lid down, instead of seeing the refraction, you can see the lower lid pattern of measurement glands. So normally they are white, they are like this. So micrography is the most important test. Because why? Because measurement gland is the most common type of dry eye. So micrography has to be present in basic examination. So we have 3 tests. One is this fluorescein simple test. Number 2 is the tear film breakup time along with fluorescein. Fluorescein staining, fluorescein tear film breakup time. Staining and breakup time. Then we have the Shivers test and then we have the micrography. So these 3 tests have to be done routinely in clinical practice. in a dry application. Then we have other tests like border topography, or what's called a topography. We see the surface of the border. These are very for research purposes. One more test is called phenol red test. That's called phenol red test, in which there is a thread-like thing put in the inferior corners. And then you see that becomes orange red, and you see how much the wettability of that thread. That patient does not perceive that is in the inferior corner. That's called phenol red test. There is one more test that's called hyperosmolarity. That's called hyperosmolarity. What's hyperosmolarity? Hyperosmolarity means the osmolarity of the tears is very high. It is very high. What is normal osmolarity and what's abnormal osmolarity? Normally the osmolarity is less than 290 milliosmoles per liter. Milliosmoles per liter is normal. Okay. And if it is above 316 milliosmoles per liter, it is abnormal. It is abnormal. It is high. And in between the 290 and 316, it's borderline. It is borderline. So what happens with hyperosmolarity? If the tears become hyperosmolar, what will happen? It will induce cell death. It will induce apoptosis. It will induce apoptosis. What happens? Suppose tears become hyperosmolar. What will happen? They will draw the fluid from the cells. They will draw the fluid from the cells. And cells, in a reflex, they imbibe more fluid. They become abnormally distended and they rupture. This is how the cell death occurs in the hyperosmolar state. But the important thing is, in some patients, you can have a normal osmolarity, but cell death is 60 to happening here. There is more variability in that. Suppose it will be 280, next moment if you measure it will be 360. But in normal population is a uniform pattern, like 290 to 300, like that. So more variability speaks of the patient has been dry. But hyperosmolarity does not tell us whether this is aqueous deficient eye or it is a evaporative dry, or it is a mild, it's a moderate or severe. So it does not tell us. So it is not an important test for us clinically. So, but from research point of view, it may be important. So this was the hyperosmolarity. Other important is the inflammation. Is inflammation, because inflammation is part of the dry eye. Inflammation is a part of the dry eye. How we can measure inflammation? Inflammation is measured by markers. Inflammation is marked by the markers. What are the markers of inflammation? CRP. No, in this there is one marker that's called NMP9. NMP9. So there are some machines which measure the NMP9 level. There are some machines which measure the NMP9 level. And if NMP9 level is more, it speaks that the patient has high inflammation in the eye. What is the normal and abnormal NMP9 level? 40 nanograms per ml. If it is less than that, it is normal. If it is more than 40 nanograms per ml, it is abnormal. There is one more thing, that there is some reflex. The eye is a reflex. Suppose corneal intact, corneal reflexes is a stimulus for what? For the tear production. If the corneal sensation is lost, tear production will be affected. This is called a reflex arc. This is called a reflex arc. How this reflection is affected? Suppose cornea becomes sensationless. Okay. Suppose there is a eighth nerve damage. Okay. Ophthalmic or trigeminal nerve becomes damaged. Okay. Then the herpes zoster, yes, exactly. Herpes simplex. Even the neurotrophic keratitis. So all things can decrease the aqueous production. Sorry, lateral gland production.
Corneal.
Production. Lateral gland will not secrete. Lateral secretion. So the reflex arc is affected. What else can affect the reflex arc? Contact lens. Once contact lens is put on the cornea, it affects the reflex. So what is this? The nerve which secretes which supplies the lacrimal gland. Which is ganglion is pericopalatine ganglion, from which post-secretory fibers go to the lacrimal gland, and lacrimal gland secretes the tears. So all these things, so there are three things. One, that basic I have told you. Now, secondly, we have hyperosmolarity, which is important. Then number second, we have the inflammation. Hyperosmolarity is major. I have told you time. Then the inflammation is major. I have told you how it's major. And then P9 Then third, it is a reflex problem. That the cornea is damaged, corneal nerves are damaged, or corneal sensations are damaged due to trigeminal nerve problem, damage to trigeminal nerve, or if the cornea has herpes simplex, or if the cornea has herpes zoster, or if the neurotrophic keratitis of the cornea, it will affect the contact lens of the cornea, it will affect the reflex secretion of the lacrimal gland. So we call the reflex secretion. So other tests I have told, now I go to the management. How we should treat. Before we go to management, one idea I want to give. Generally we see some dry eye, we give it treatment. Dry eye is not a disease. It is not a diagnosis. So you have to see the real diagnosis. Whether the patient has Sjogren's syndrome, whether the patient has primary Sjogren's syndrome, it has secondary Sjogren's syndrome, it has maybe mental abstract function, or there is some other cause for it. So we have to reach the cause. So etiology wise, what we are doing, we are establishing patient as dry, but that is not a diagnosis. We have to reach the diagnosis. What is the diagnosis? Why it is dry? Whether there is a acute deficiency or there is a cooperative dry, and how much is the severity of the dry? Management now, patient has dry eye, now we want to treat it. Suppose there is more of inflammation. What do you do? You use anti-inflammatory. What anti-inflammatory? Huh? Steroids. No. You can give small doses of steroids, slowly on for a short time, but generally they are not preferred in dry eye. What anti-inflammatory is preferred? No, cyclosporin. Cyclosporin or tacrolimus. Cyclosporin or tacrolimus can be given for inflammation. But the problem with them is what? It takes a long time for them to have effect. It takes minimum 4 to 6 months. How much? 4 to 6 months to have an effect. So one should not expect it within 1 week or 2 weeks like that. So these are the anti-inflammatories. Then the lubricants. We have different classes of lubricants. One is the cellulose, like carboxymethyl cellulose, hydroxymethyl cellulose. Then we have the cellulose. Then we have the polyenes, polyethylene glycol, polyethylene glycol. So these are the glycols. Then you have polyvinyl alcohol. Then we have the povidone. Then you have the viscous type of lubricants. These are two. One is sodium hydrogenate and other is bondrite sulfate. Sodium hydrogenate and bondrite
Sulfate.
So what is the problem with this philosophy? What is the lubricants? What is the problem with the lubricants? Number one problem with the lubricants is they contain preservative. They contain preservative. Once they contain preservative, they cause irritation of that. They cause irritation. They can cause more dryness. Generally, what are the different preservatives? One is called benzalkonium. Benzalkonium. Benzalkonium is the one. Normally expressed. Then you have polygon. Then you have some like sodium perborate. You come forward. How to go forward? So sodium perborate is one more preservative. So even is not interested, we mark that as a name. I have no problem. Seriously, if somebody is not interested, he marks the attendance at it. So sodium perborate is one more preservative. But generally what happens, once we put a drop, the preservative gets diluted 8 times in 30 seconds and 16 times in 1 minute. So fast the dilution. Okay? So they are not that bad. Suppose there is no conjectural coral staining, you can put a lubricant with preservative. But if there is already a damage on the conjunctiva cornea, then we should go for preservative if it lubricates. One more problem with these preservatives is that viscosity. They should be viscous. What is the problem with viscosity? Suppose the patient has taken a lubricant wire. He has put in this temperature here. So that will not retain viscosity. So we should advise such patients to put in the refrigerator these days. Okay? Suppose somebody goes, he takes a lubricant, puts it in his vehicle, and after 2 hours he puts it. That will lose all the viscosity. So the viscous substances are to be refrigerated. They are to be refrigerated and then they are to be used. Number third problem with these lubricants. Oh, Mr. You're talking to me. After this, sit there and go there. So, number third problem with these viscoelastics is what? One I told the preservative, other I told the temperature. After better number second is the refrigeration, the temperature. Temperature, they should not be used at high temperature. Number third is the frequency. Generally, we observe the amount of writing only eye drop or drop which one drop 4 times. Only polyethylene glycol, 1 drop 4 times. That's wrong. Because the half-life of these drops of the methyl cellulose is hardly 30 seconds. Within 1 minute it goes so fast it is. Now something is done for like chlorobenzene, which is more viscous. So its half-life is around 5 minutes. How many? 5 minutes. So within 10 minutes there is no viscoelastic in the, no lubricant in the eye. So generally we should prescribe these drops more frequently, like every 1 hour, every 2 hours, like that. So frequency. So these are the 3 problems with lubricants. Number 1 is the number 1 is preservative, size. Number 2 is temperature, and number 4 is the frequency of distillation. Then one more we have is the one more class of drugs. Suppose we have put the patient on lubricants and patient is not responding. What else we can do? We can give some hypersecretory type of drugs. Those are called secretagogues, which increase the mucin production or the DHA production. Anybody knows of the drug which can increase? One is very good. So one prescribed drug is the pilocorpine, tablet pilocorpine. So tablet pilocorpine is 5 milligram tablets. So it increases what? It increases the tear production, it will increase the salivary production, and it will cause the sweating. So these 3 things, it will cause sweating, it will cause the saliva production, and it will cause the tear. When there is a drug, this one drug that is some name by dicafusol, dicafusol, dicafusol eye drops. It is an agonist of the receptor P2Y2. P2Y2 receptor, and which increases the mucin production. Another drug is ribupamide. That is a ribupamide is a quinolone derivative. It's a ciprofloxacin-like drug. Okay, ofloxacin-like drug. It is given by the gastroenterologist for peptic ulcers. So it secretes more mucin. So these are the 3 drugs that are called secretagogues. Now, I told you the main problem is this time is the labial gland dysfunction. How do you treat that? One is the hot compresses. What is the hot compresses? But you should know how to give hot compresses. Upper lip you have to give upside down, and lower lip is given like this. Okay, this is upside down, and this is like this. And there are some forceps also. Which will press on the labial gland and express the secretion, so that the ducts become open. Those are the forces. One more is that's called lippy flow. Lippy flow is a technique in which it is placed on the wrist, and it gets vibration with heat. So it matches the secretions of the labial glands, and it will infrared heat and intense pulse light therapy. The intense pulse light therapy and the infrared, what's called heat therapy or mask therapy. That's called heat therapy or mask therapy. It is multiple mechanisms. What it does, it gives energy to the mitochondria. Once it gives energy to the mitochondria, the labial gland becomes metabolically more active. They rejuvenate. And other thing is already there lip. Between the anterior border and posterior border. So we recommend ducts open. There is vascularization of those ducts. It destroys those vascularization. That's called destruction of the neovascularization of the late margin. That is happens with this IPL therapy, intense pulse-like therapy, or by the infrared beam therapy. Let me kind of I want to finish it. I don't want to leave. This is it. Let's take 5 minutes. No, sir. Huh? Yeah. You are not interested in writing alongside me. Don't need. Go first, go first. Keep quiet. So I want to finish it. So we have lastly, balance. Lastly, we have one more thing. These are very important points you should know. I am telling you for your people. I can finish it. One more thing is the pH. One more important thing is the pH of the eye, pH of the tears. So if you are putting some drug like cyclopentylate, you are putting cyclopentylate or you are putting aminoglycoside, it creates an acidic pH. It creates an acidic pH. And once it creates an acidic pH, what will happen? The lubricants will not work properly. Okay? Lubricants will not work properly. Another form of therapy across deficient eye is called plugs, punctal plugs. They are called punctal plugs. So we plug the punctal. We put some plug in that. There are temporary plugs and there are permanent plugs. What are temporary plugs? It is like this. Temporary plugs are collagen. They are collagen plugs. And once we put the collagen, important is there are two conditions. Nasolateral duct should be open, number one. Number two, after putting the plug, patient should not have exposure. He should not have water. Once you have seen that after 1-2 weeks, then you do a permanent plug. Permanent plug. Permanent plugs are what? Made of what? They are made of silicone. They are made of silicone. One more thing, you think some patient has more severe dry eye. What you can do, you can do a punctal pottery. You can burn the punctal, upper and as well as lower, so that drainage is not. So it's done in a very severe type of aqueous deficiency. Then we have one more is the torsorrhaphy. What's torsorrhaphy? Torsorrhaphy is that we just join the two lips. We make some raw area here in the lower lip and in the upper lip, or we divide them, then we join them. Like that, 1/3 of the lip like this. The aperture is decreased. Okay, so it preserves it. Suppose some patient is very severe dry eye and he has some indolent ulcers. He has some indolent ulcers over the cornea developing because of the dry eye. We can go for this torsorrhaphy. What is the other indication for torsorrhaphy? Then we should. The patient has Bell's phenomenon, Bell's palsy, we do torsorrhaphy. But dry eye is one more is community torsorrhaphy is done. Other indication is ectopia. Other indication is ectopia. So these are the three indications for torsorrhaphy. One is the seventh nerve palsy.